Hello, everyone. So welcome to NACHW's webinar. We're gonna go ahead and get started by launching a poll. So this is a follow-up webinar to one that we hosted on October 9th. We had a couple of technical difficulties and we had a lot of follow-up questions from attendees. And so we decided to hold this webinar as a follow-up to that original one. So we're going to go ahead and launch a quick poll. And from that poll, we want to know if you participated in the webinar on October 9th, if you watched the YouTube video, if you did both, or if you did neither, just so we can gauge the audience today. So please go ahead and participate in that poll. It should be up on your screen. If you're on mobile, if you just click on your phone screen, it'll be on the bottom menu toggle and it'll say poll, and sometimes there'll be a 1 next to it. It may not pop up directly onto your screen. All right. Got about 4 more people, about 6 more people who have yet to participate. Give everybody a couple more seconds there. So again, this is a follow-up webinar to one we had on October 9th. So we just want to know if people were here or if this is their first time interacting with the material. All right. I think we can end polling. So it looks like most of the people on here did neither, so which is great. You will be hearing this information for the first time, and I'm sure you'll have lots of questions. And some of you, about 20% of you, were here on the 9th. 3 of you did both, which is great. So welcome, everybody. All right, Carl, could you go to the next slide, please? So welcome. Oh, one more bit of housekeeping. I will be checking out the chat, and in the chat, as Carl goes through the process and talks about different links, I will be posting those links in the chat, so you'll be able to just click on them and see exactly what he's talking about. I will also be taking questions in the chat, so as we go through, just drop your questions in the chat, and I will be sure to read them to Carl at the end, or if you would like to read them yourself, you can go ahead and unmute yourself and do that during the Q&A portion. So a little bit about NACHW. The National Association of Community Health Workers was founded in April 2019 after many years of planning and advocacy among CHWs and allies from across the country. Our vision is a workforce of community health workers united across geography, ethnicity, and sector, supporting communities to achieve health, equity, and social justice. Next slide, please. We are honored to have membership in 48 states across the United States. Memberships for CHWs begins at just $20. Please visit our website and you can download your individual or organizational level membership packet. And that website is www.nachwa.org/membership. And that's what the page looks like. Next slide, please. Our board of directors are representatives of community health workers and allies from across the country. In August of this year, we elected 6 new members, 4 CHWs and 2 allies. You can visit our About Us page to see the list of our board members. And again, we have a couple of them on this webinar tonight. Next slide, please. Thank you. We also have the National Ambassador Program, which was launched in 2019. This includes 20 ambassadors from 19 states who work with NACHW to expand our connections to local and state CHW efforts and to engage our members and partners in collective action. Next slide, please. These are our sponsors and they help make our work possible. So thank you to each of our sponsors. Next slide, please. And I would like to introduce Aurora Grant Wingate. She's our new member and partner engagement coordinator to tell us a little bit more about a new project.
Hello, everyone. Thanks for being here today. My name's Aurora. NACHW has recently embarked on a partnership with the Morehouse School of Medicine working on the National COVID Resiliency Network. This is funded by a grant from the National Office of Minority Health. And it's to create a structured national network of resources to mitigate the impact of COVID-19 on racial and ethnic minority and rural populations. Kind of NACHW's role in this partnership is to help devise kind of a strategic plan and to help get community health workers involved and bridge that gap between what Morehouse School of Medicine is doing and the expertise of community health workers on the ground. If you have questions, if you would like to get on our mailing list about NCRN, please go ahead and email me. I'll also put the link to Morehouse's website in the chat. Thank you.
Thank you, Aurora. We're really excited about that project. Next slide, please. So, in August of 2020, NACHW launched the CHW Document Resource Center. Documents found in this resource center are most useful for state government officials, CHW leaders, current and potential employers and payers of CHWs, and other individuals and stakeholder organizations involved in considering policies on CHWs. This database is not source for individual CHWs looking for tools to inform or improve their practice. This database was supported and funded by the Center for Disease Control and Prevention. The main use of this resource center is to find information on the process other states have gone through in advancing policies around CHWs. This can help you understand policy options available to your state or to learn about experiences in other states who have pursued policies or investments similar to ones you are considering in your state. Next slide, please. Perfect. And now I'd like to Carl Rush. Yeah, take it away, Carl.
Okay. Thank you, Bernadine. Welcome, everybody. We're glad to have you with us. We're going to make a little adjustment. We were assuming that most of the people on this follow-up webinar would have participated in the original one where we didn't have a whole lot of time for discussion. And so we are going to spend a fair amount of time today on discussion, but since a number of you have not participated in either one, the October 9th webinar has been recorded and you can see on your screen, and I'm going to ask Bernadine to put that link in the chat if you want to copy that for future review. And the webinar is really built around this report, and this link is also available. You can get to it, of course, through the NACHW website. But this was the result of a number, including the policy work that we've been doing with the CDC, a culmination of what a lot of folks have been doing in a number of different states. And I'm going to summarize very quickly what is in the report. I encourage you to go to the report to review it directly. Start by saying, of course, that sustainable financing is, I'd have to say, sort of the next step. The reason we're talking about sustainable financing is largely because of the frustration of the work of community health workers being financed through short-term grants, which is not sustainable, and it causes a lot of stress for the workforce itself in terms of unstable employment and that sort of thing. But it also is, in some ways, a disservice to the communities that you are trying to serve. And the other concern that we have with grant financing is that it often puts community health workers in silos. That the natural impulse of community health workers is to respond to people where they are, what their needs are in the community. And oftentimes grant funding dictates that you spend most of your time on a specific issue like diabetes, let's say. So the first question, of course, is what do we mean by sustainable financing? And by that we mean that the funding for positions are simply not dependent on applying for these kinds of grants and contracts on a regular basis. And you can get there in a couple of different ways. One is by linking to an ongoing revenue stream, and no big surprise, the big one that we do focus on in the report is Medicaid, but that these funding streams explicitly provide for coverage of CHW services rather than being an exception. The other option, though, is, and we're hearing more and more examples of this, is organizations that have simply integrated community health workers into their core budget, that they are not relying on a dedicated source of funding for those community health worker positions. And that gives the organization and the workers themselves a lot more flexibility. And of course, since I've already mentioned Medicaid, that the jargon that we've become used to is talking about Medicaid reimbursement. And reimbursement tends to connote or suggest to people fee-for-service payment, where the Medicaid program or a Medicaid health plan is billed for units of service by the CHWs. And that can be in many ways the hardest way to pay for community health worker activities. Now, the report goes on to say, and I hadn't planned to spend a lot of time on this, but the report goes on to talk about certain basic principles about how to approach sustainable financing or strategies for it. And this can be done at the organizational level, or it can be done at the statewide level. And increasingly, there are initiatives to establish the funding streams for community health workers at a statewide level, rather than each employer or program trying to come up with their own strategy. So that's a general trend. The other thing we need to keep in mind is that certainly for Medicaid, which is the elephant in the room, so to speak, that the majority of states operate under a managed care system. And increasingly, we're seeing state managed care contracts contain language that specifically refer to community health workers. So that's a positive trend. But about 2/3 of Medicaid recipients around the country are served through a managed care arrangement. So some of the other general principles, just to be very brief on this, have to do with the idea of starting from a general notion of what you want community health workers to be doing. In other words, it needs to be a step beyond the idea of telling payers, you need to be paying for community health workers. You need to tell them more than that. I think that should be pretty obvious, but it's also really important to tailor what you are proposing to the climate in your state and what the priorities and needs of the payers are. That would seem to go without saying, but it's a really important step. So in the report, the real guts of it have come down to 2 pages, which are policy options. Excuse me. And those options cook down to, we've categorized them in seven categories. And these are, this is, I apologize, it's a little difficult to explain the difference between a strategy and a policy option. What the strategy is really more about what the structure is that you want to establish, and the policy options are the tools that you can use to get there. So there are several that involve Medicaid specifically on this first page, and that includes waivers and state plan amendments, which we can talk about as well. And they're quite a few states that have established payment for community health workers through this mechanism. The second one is the contracts, as I said, with health plans or managed care organizations. And there are 3 or 4 states at least that now have requirements in their standard Medicaid contracts requiring or encouraging, in some cases, the health plans to include community health workers in the services that they provide or pay for. And then there are plenty of Medicaid health plans out there who are doing stuff already on their own without incentives or mandates from the state. They're doing things on their own. And the simple fact is that for the most part, if the health plans are willing to treat the expenditures for community health workers as administrative costs, they can do pretty much what they want. They, in many ways, don't even really have to ask permission to do it. And so there are a lot of them who are doing that. Some of them are hiding their light under a bushel, so to speak, but there are a number of them that are becoming much more public about it. The next set of policy options are a little more sophisticated, perhaps, but the way healthcare finance is going in this country, and this applies equally to Medicaid, is that they're getting away from fee-for-service toward alternative payment mechanisms or value-based payment. You'll hear terms like bundled payments and global payments and capitation and per member per month and that sort of thing. And those structures, by and large, give the providers or the employers of CHWs a lot of flexibility, where as in the past, they may have needed to stick to clinical services as the basis for receiving Medicaid payment. There's a lot more that they can do. And this includes, in a number of states now, the Medicaid health plans investing directly in things like housing and employment programs, because they recognize that stabilizing people's housing situation can really have an important positive impact on their overall health. The next category I've already alluded to, and this seems to be growing, I think, the organizations that are financing community health workers internally, which removes them from dependence on grants and contracts, maybe not 100%, but substantially. So there are provider organizations like Baylor Scott and White here in Texas, who have, I believe, over 100 community health workers now, which are really, again, financed in various ways. But the one I learned about just this week is the New York City Health and Hospitals Corporation. And they have a community health worker program, which is entirely internally financed. It may take a while before they expand it to a really large scale, but they really like the flexibility that it gives them by financing it themselves. The next one, federally qualified health centers, FQHCs, are a little bit of a different animal in that many of them are funded under what they call a prospective payment system, which is a per visit payment that they receive for each visit that an individual makes to their clinic. And the rate that they are paid is based on their overall cost, their total cost. And the problem is that a visit with or contact between a patient and a community health worker alone, it does not count as a visit, does not count as an encounter. And so there are various ways that they can get around that. But there are a number of health centers around the country that have found ways to integrate community health workers into their regular payment system. And this is a very promising opportunity. Some of them have found ways to encourage or persuade Medicaid health plans to incorporate community health workers into the payment rates that they use. And then lastly, there are a number of programs around the country that have applied a strategy of diversified funding or blended or braided funding, in which they have a combination of sources, which makes them less dependent on any one of those sources. And one example is the Pathways Community Hub model, which is operating in about 20 states right now. So they can be receiving funding through Medicaid or through private charity, through United Way, through local government, any number of sources. And actually, you could classify. I mentioned Baylor Scott and White, and they could actually be considered an example of this option as well. So I invite you to go back to the report itself and review all of this basic background. But we wanted to provide, we've got a little over half an hour remaining for discussion. And what I would like to do is float some of the questions that we have, excuse me, heard already, and see what you would like to delve a little bit further into. I've got a series of 8 questions, which I could leave on the screen. I don't want to steer you in the direction of these questions, but they have come up before. And you are welcome to pose any of these questions for further discussion or questions of your own. And in the process of discussing them, I really want to turn back to you all. And it's not, I don't want this to be a situation where you're all asking me questions. Where possible, I really want to turn back to you and say, what's been your experience in your state or with your organization with this kind of issue, so that we can get some further input into the discussion. So the first one, and I think we sort of need to get this out on the table as the National Association. There are certain things that NACHW will take policy positions on. This is not one of them. That NACHW is not proposing a specific strategy for CHW financing. And we can talk about that some more, but it really is a matter to be decided at the individual state level or even the individual employer level. So there are plenty of options, and we encourage people to explore them. The next one, and this one may be moot now based on what we're hearing this week about the Affordable Care Act. There was an attempt in 2017 to repeal it, which did not happen. And you're probably all following the arguments were just heard in the Supreme Court this week. And it does appear that the justices may be reluctant to overturn the Affordable Care Act as a whole, which is good news. But we can talk some about what aspects of the Affordable Care Act are important to community health workers, if that's what you would like to address. This has come up a number of times, that there are workers, there are a number of different titles, but they're peer support specialist is a very common one. And these are, I guess, most common in behavioral health care. But the model has been applied to a number of other things, like HIV/AIDS, for example. And the work is very similar. The skill requirements are very similar to those of community health workers. And yet it seems there are some states that have been willing and able to provide Medicaid payment for peer support specialist services, but not community health workers. And so there's some interesting opportunities or questions about whether we want to explicitly draw that connection and use the payment policy for peer support to expand that to include CHWs. This is a big one. The report does not deal with certification, individual certification of CHWs, but this comes up a lot. We have heard in some states, for example, anecdotal accounts that payers insist on at least some standard qualifications for CHWs before they're willing to pay for them. The bottom line, though, truth to tell, is that the certification is not necessary for a lot of the experimental efforts at paying for community health workers that are going on now. There are states that don't have certification where there's a fair amount of activity in Medicaid financing of community health workers, for example. And there are other options. So this is an interesting topic to explore further. But I guess the point is that I will just use Texas as an example. We had legislation leading to establishment of certification that was first passed in 1999. And the purpose of the legislators when they wrote those bills was they said, we want to get Medicaid reimbursement for CHWs. And so the state adopted certification and nothing much happened for about 10 years. So certification by itself will not get you to sustainable financing. A lot of other things need to happen. So it's not the answer. It's not the panacea. There is a lot of talk about return on investment for CHWs. And it is clear that employers, payers, state Medicaid are interested in the issue of return on investment. If we're going to put money into community health workers, will we see a benefit in terms of controlling other costs? But there are other outcomes that are meaningful to these folks, and it's important to look at the big picture. It doesn't necessarily serve community health workers well to say that the only purpose to pay for community health workers is to save money. I think that's selling the profession short. And there are other, clearly other compelling reasons to include community health workers in services. The last couple of questions are a little bit mechanical or, how shall I say, administrative in nature. But I guess Medicaid, it's important to say that Medicaid is very much decided on a state level basis. There is no, technically no Medicaid funding that flows directly from the federal government to providers. It is explicitly set up as a federal state partnership. So that we can set that question aside. The matter of a state plan amendment, it is, of course, Medicaid requires non-federal match, and the state is going to need to meet its obligations for non-federal match. And it's very difficult for me or anybody else coming at this from a national perspective to say how best to lobby for that at the state level. It is definitely a matter for the detailed politics of your state to determine how best to approach that. So those are some of the questions that we have already anticipated, and so I think it's time for us to go directly into discussion, and let's see what folks are asking. Bernadine, are we seeing questions?
Yes,
posted.
Yes, we have 2 questions so far. So the first question is from Carol West, and Carol says, California has chosen not to use a state budget amendment. Do you know how, if any way, in any way CalAIM will help CHW funding?
Okay. Hi, Carol. Thank you for that question. Very, very important. There were a couple of programs in California that had high potential for involving CHWs. One was a health homes program, which is kind of like a patient-centered medical home for people with complex needs. And there was also an initiative called Whole Person Care. And CalAIM, I forget what the acronym stands for, but CalAIM is a proposed replacement for those two programs. And there is a lot of discussion about roles for community health workers in CalAIM. In fact, there is a program, a process that is now underway, funded by the California Healthcare Foundation. They just had their first advisory council meeting last week. And there is a lot of enthusiasm. There's sort of an advisory council, and then there's a stakeholder group that they are convening. And they are definitely going after specific strategic proposals for CalAIM. Now, this is kind of an inside, if there are at least one or two others of you from California, but that is definitely on the front burner now. And it seems like the state is very interested in specific proposals to include CHWs in CalAIM.
Yeah, because one of the, sorry, I'm not sure if you can hear me, but
Yes, we can.
Yeah.
Go ahead, Carol.
Okay. Hi. Because one of the other things that's happened is the peer support specialists have had a bill on the books for the last 4 years that actually passed last year, well, this year, September 25th, SB 803 for peer support specialist peer certification. I know from the Bureau of Labor and Statistics that peer support specialists are in fact under the community health worker umbrella, but the process in California seems to be running independently of the community health workers.
Mm-hmm.
But what it has passed basically is a pathway for certification, and I do understand that doesn't necessarily lead to funding, but it does include the requirement for CPT codes or billing codes.
Mm-hmm.
But when we approached our local county, because one of the compromises that they had to make was that it would be each county, and there are 58 in California, will have to opt in individually, which is mind-boggling. But
yeah, sure.
Our county director was basically saying, you know, we really want to move away from this fee for service because it has not worked very well as a mental health funding mechanism, because the billing for a lot of reasons has not been done. And so they have not been reimbursed for a lot of services that were provided. So we were really hoping that I know that CalAIM kind of changes were put on hold because of COVID.
Right.
But that as that moves forward and we do move towards value-based care rather than fee-for-service, that we might move out of that dilemma. Yeah.
Well, yeah, and that is clearly a potential. I need to sort of unpack what you're saying, because you combined a number of important issues here. The CalAIM is going to be generally for people with more complex needs, and there's a lot of agreement that community health workers can be very helpful in assisting people in that situation. But it is California is a little bit different in that the counties have a little more of a role in this than they do in most other states. The other point you make, though, is that it's been easier for, as I said in one of the sample questions, for some states to get reimbursement for peer support workers. And that is very often paid for in a per visit or per hour kind of unit of service basis, fee for service. And it's fairly easy to identify the kinds of, or the billing codes. You referred to CPT codes. Folks often refer to them as billing codes as well. And it's relatively easier to define those for peer support specialists. The crucial thing here is that it seems like in most of these states that it's easier to establish billing for peer support folks, even though they have many of the same skills and they're doing a lot of the same kinds of things that community health workers do with other individuals or families. That the key point, one of the key points in the definition of the community health worker and the peer worker is lived experience in common with the people that they're serving. And I think that's a concept that we all understand and embrace. The key distinction is that with the peer support worker, that lived experience, or the most crucial part of lived experience for them, is experience with a particular health condition or issue. So if it's addiction or mental illness or that sort of thing, it's pretty easy to define that someone with a history of experience with those conditions is in a unique position to help somebody who's going through the same things. That makes a lot of sense. What's crucial for payment policy is that that is a qualification based on a medical issue. And so the states have found it easier to get authorization for payment for services when the provider, if you think of the peer support person or the CHW as a provider, that the provider's qualifications are defined in terms of a medical issue or medical condition, that it's easier for policymakers to wrap their heads around that. The crucial qualification for community health workers is lived experience in more of a socioeconomic sense. In other words, it's more important that they have been through experiences of poverty and racism, that sort of thing, and able to establish peer relationships on that basis. And that is a lot harder for the healthcare system to understand and work with. So, but thank you for that question. There's a lot happening in California. And by the way, those of you who are not from California should be aware that there was a lot of work done on statewide policy around community health workers with as part of a workforce commission a couple of years ago. And the general consensus was not to recommend individual certification of CHWs, but to propose establishing some common standards for training. And that's, certainly in many ways accomplishing the same thing. But that's the approach so far that California seems to be taking. Okay. Next question, Bernadine. You have another one here?
Yes, we have a question from Valerie. And the question is, some MCOs that I have spoken to feel that it might be counterproductive to mandate them to pay for CHWs without having the cost supported. Has that been something that you have heard?
Sure. Thank you, Valerie. It's understandable that if we've all heard the term unfunded mandate, when anybody, it could be a local government or it could be a private organization, that they're being asked to do something without money to implement it. It would be considered an unfunded mandate. There are at least 3 or 4 states that have mandates in their Medicaid managed care contracting involving the employment of CHWs. In the case of Michigan, for example, that they are required to offer the services of community health workers at a certain FTE ratio. I believe the most current ratio is 1 CHW per 5,000 members. And that's not a lot of staffing. But the point is, though, that that's in the standard contract, and the capitation or premium rates that the health plans are proposing or requesting have that in mind. In other words, you're going to pay us however much it is, $500, $1,000 a month per member, depending on the category of patients that they're talking about. That they are baking that in. In other words, if they know they're going to have to provide those community health worker services, then that's in the standard contract before they bid. So they have the opportunity to include those costs in the assumptions behind the bids that they make. In other states like New Mexico, requires the health plans to offer a kind of care coordination service to their members. But the health plan gets a supplemental payment of so much per member per month for the members that they provide those services to. So there's a separate set of reimbursement. I think it is a reasonable request. It's a reasonable concern. The other argument that you can make, and we often do, is for them to look at what benefits do they derive in a business sense from paying for community health workers themselves, with or without a mandate. And there are plenty of health plans that have seen that already, so they don't necessarily resist it. And as I said, there are only a few states that I'm aware of that have that kind of mandate. In Pennsylvania, there is an incentive or an encouragement, but not necessarily a mandate. But the health plans have learned from experience that it's in their self-interest to do what is being requested. So there are a lot of different ways to get at that. But I think what we're seeing is that increasingly the states are including provisions like this in the proposed standard health plan contract. So the health plans have every opportunity to incorporate the cost into their bid. And if they're all required to do it, then they're all including those costs in their bid calculations. Okay.
Great. And Valerie had a follow-up question, which was, is this the same justification for doula reimbursement?
It probably is. I'm wondering, Valerie, can we get you to unmute and explain what your follow-up question is? Where are you going with that?
Sure. Valerie, I've just asked you to unmute. You should receive that request. That's all right. We can always circle. Oh, okay. I think that worked. Maybe not. That's all right. We can circle back to this question while I try to figure out the unmuting on Valerie's end. We have a question from Carol that says, are there ways to capitalize on the number of people being hired into the CHW positions for the purpose of COVID contact tracing and funded by COVID funding and outreach for emergencies paid by FEMA?
Yeah, Carol, another good question. There's a really good argument, and NACHW has sponsored webinars on community health workers and COVID. There are very good arguments for community health workers being very effective in not just contact tracing, but making sure that people have the support that they need to comply with guidelines for things like quarantine and that sort of thing, because as we all know, the pandemic has caused a lot of economic distress, and people who feel that they can't stop working. They are not in a line of work that allows them to work from home. And so it creates a hardship if they are required to quarantine as a result of contact tracing, things like that. So there are some groups around the country that have done this. The one that I find very exciting is in Baltimore. It's a thing they're calling Baltimore Health Corps. And they are hiring, they're almost done hiring over 200 community health workers to work in pandemic response. And so this is a combination of contact tracing and referral for assistance if people have employment issues or transportation issues or food security issues, for example, as a result of the pandemic, that they can respond to those. But this was funded in large part by the CARES Act, which was the big stimulus relief bill that was passed, I believe, back in May, I don't remember. But they're hiring a total of 300 people, of whom 216, I think, are CHWs. They are thinking long term about the employment of these folks. So it is, in a lot of ways, it's a workforce development initiative, as well as a pandemic response initiative. So there are opportunities like that. I think if you Google Baltimore Health Corps, you should be able to find out more about that. But they just presented on a webinar this week that I saw. So.
Great. And circling back to Valerie's question about the justification for doula reimbursement, this was related to peer recovery specialists and doulas.
I wonder if there's somebody else on the call who can respond to that, if we can figure out how to get you on. I am not that well versed in the connection between them. I know there are states that are paying for doula services under Medicaid, no question about that. But I don't think that the policy mechanism or the rationale in policy is the same for the two. There are some states that are further ahead on the doula issue, like Illinois, for example. But I don't. It's a little over my head, I think, policy-wise. If somebody has some suggestions about the connection between doula and peer support funding, be glad to hear from you.
Great, thank you. And we have another question from Refilwe, which says, have there been any emergency COVID-19 1115 waivers? For example, contact tracing and CHWs have been included.
Yes, hi Refilwe. Glad to have you with us. I am not aware of any waivers specifically for this. It is very likely there have been some. Again, there's an issue here in that Medicaid generally is only supposed to be providing services to Medicaid recipients. And so this creates some challenges if you're trying to justify, for example, contact tracing. The virus doesn't really respect the boundaries between Medicaid eligible folks and non-eligible folks. And so it's I wish I had more current information about that, but that is it's a very interesting challenge. And again, if somebody else on the call has some suggestions on that one, would certainly like to hear from you.
And those are all the questions we have in our chat. We have time for maybe one or two more. If you have a question, feel free to pop it into the chat, or you can raise your hand, and then I will unmute you and you can ask it live.
This is Carol again. I'm wondering if other states, this is kind of less about funding and more about policy, I guess. What I have noticed happening in Sonoma County is that while it's been incredibly difficult to get HR to recognize community health workers up to this point, when the money came through with the CARES Act for community, for contact tracing, contact investigation, there were a number of positions opened up with the title community health worker. But I believe many of those have been filled by furloughed public health workers who have never been through a community health worker training. And truly, if you ask them what a community health worker is, I'm pretty darn sure most of them would not even know what a community health worker is. They have been given on-the-job training for contact tracing and contact investigation. So moving forward, when hopefully COVID is over and done with, do you see any issues in terms of workforce development and recognition of who community health workers are because of the COVID need for immediate training of contact tracers and contact investigators?
Sure. Well, those kinds of positions, you're right, have been filled by people who come from very different backgrounds. They've even had They've even assigned military personnel in some places to, which, may work with some populations. In terms of a lot of the populations and communities that we're most concerned with, the military would not be the first people I would send in to do contact tracing. This is an illustration, though, of the importance of getting widespread understanding of the definition, whether you have something like certification or not. It's really important in each state for people to have a common understanding what the definition of community health worker is, because you're absolutely right that people may think anybody who does public health work in the community is a community health worker, and that is simply not the case. Terminology is incredibly important. One of the things we ran into in the early days of the Affordable Care Act with the marketplaces, that the federal funding was available for what they called navigators.
It won't be long.
And the intent of the term navigators was the organization that did the outreach. It was not the individual worker. But many people have leapt to the assumption when they're talking about ACA navigators that they're talking about individuals. And as a result of that confusion, some really potentially valuable legislation, CHW legislation in Florida, got killed by the governor because he saw or his staff, I assume, saw the term navigator in the bill and said, no, you can't do this, because he was not supportive of the ACA. And so that kind of confusion can be really, really damaging. I want to turn, let's see. I see there's a couple of questions here, and we're about to run out of time. And I believe that assistance in completing Medicaid applications can be covered as an administrative cost. But the question was, would CHWs providing assistance to families in the completion of Medicaid applications be a billable Medicaid cost? It is not. Again, part of the definition that said is that Medicaid can only provide services to Medicaid recipients. And if you're an applicant, then you're not yet a recipient. But basic needs assistance, there are some states that are getting approval for Medicaid to pay for housing assistance, employment assistance. They can already provide transportation, for example, for certain needs. That is definitely already there with or without CHWs. Last one I see, Arizona is looking at Medicaid reimbursement. We're in the final stage of rules making for voluntary certification. Is there a question there? I'm familiar with that. Part of the problem is there was legislation authorizing certification, but the state health department, ADHS, was so busy. The people who draft rules and regulations were so busy that it has taken forever to get the regulations approved. Maria, is there a question that you wanted to ask the group? Are you able to unmute?
Hi.
Yes, we can hear you now. Yes. Hi.
So just how do we make sure that we speed up the process for you know, the voluntary certification, and then how do we ensure that we are you know, not converted into like medical extenders is the biggest issue, I think.
Sure. Well, I think the folks who've been involved in advising the state are really aware of the importance of the integrity of the definition of community health worker and promotora, that they are they're on top of that. As far as speeding it up, I'm afraid that's just part of the problem of the workload or the bandwidth of the people who write regulations within ADHS. So there may not be, that's always just a practical issue that we run into. Bernadine, I think we're about out of time. Are we going to?
We are just about out of time. We have one more question. It'll probably take us another 2 minutes. If you do have to jump off, we understand. This recording and slides will be made available after this. So our last question is from Angela. And Angela says, would CHWs providing assistance to families in the completion of Medicaid applications be a billable Medicaid cost? What about other types of needs assistance provided from CHWs?
Yeah, I think we were actually able to get to that one.
Oh, did we get to that?
Not sure we had a fully satisfactory answer, but that's that's about all we had time for. But thank you.
Yes.
And
that is it.
So, and if anybody wants to follow up with me directly, I'd be happy to respond. But we appreciate your participation and your interest in the subject. There's a lot going on in this field right now. So thank you very much. And if you are not already a member of NACHW, please go to the website and sign up.
Yes, thank you so very much. Again, this will be made available, so look out for it in email. We'll be uploading the video on YouTube and sending out the slides. Thank you so much to everybody for coming, and have a great weekend.